So I'm really looking forward to this next section. There's been a lot of debate since the last ASCO meeting, particularly about the issue of metastatic HER2-positive disease. We saw, of course, the Destiny Breast 09 presented, but then we also saw data actually that Erika presented looking at tucatinib in the maintenance setting, so a lot to talk about there. And then, of course, we all of a sudden at ESMO, we saw the neoadjuvant studies and also post-neoadjuvant studies with TDXD, so a lot to unpack there. We're going to talk about HER2-positive disease, and we have Dr. Erika Hamilton from the Sarah Cannon Research Institute in Nashville, Dr. Shanu Modi from the Memorial Sloan Kettering Cancer Center, and from the Florida Cancer Specialist, Dr. Susmitha Puri from Inverness in Lecanto, Florida. So I think let's just jump right in terms of the data here, and we'll get your thoughts later on where we're heading in general with this. But first, let's talk about localized HER2-positive disease. Dr. Modi.
Thanks so much. It's really nice to be here. I'm surprised by how many of you have stayed this late. So let me just say that this past year was another big year in HER2-positive breast cancer, and we saw a number of really pivotal studies for early-stage HER2-positive disease that are really shaping or reshaping the treatment landscape. So we're going to review the data for some of these and focusing on the higher risk, stage 2 and 3 patients. So our current approach in treating these patients is to use upfront systemic therapy. And so we know patients who get a PAT-CR generally have a very optimistic long-term outcome. Those who have residual disease are higher risk, but we've been able to improve significantly their outcomes by escalating in the post-op setting. So the whole neoadjuvant model actually has been really instrumental in allowing us to sort of individualize therapy for HER2-positive patients. And broadly speaking, the field continues to shift towards de-escalation on the neoadjuvant side and escalation on the adjuvant side for the patients who warrant that. So let's start with the neoadjuvant de-escalation trials, beginning with the NeoCARP. This is now the second randomized phase 3 study that has eliminated carboplatin from TCHP. So over 700 patients were enrolled. These were largely stage 2 patients, and they were randomized to either TCHP or THP for 6 cycles. The primary endpoint was PAT-CR, and as you can see, the results are virtually identical, and that was consistent across the hormone receptor status groups as well. So what we're really waiting for are the long-term event-free survival data to sort of formalize this as our official standard of care. COMPASS HER2 is another de-escalation trial, not just eliminating carboplatin, but also decreasing the number of cycles of THP from 6 to 4. Over 2,000 patients were enrolled to this study. Again, these were largely stage 2 patients. PAT-CR was a secondary endpoint. And you can see on the right, overall, the rates were a little bit lower than we see with the 6 cycles, but in selected groups, the results, like the hormone-negative population, the IHC3+ population, the results were still quite impressive. The primary endpoint of this trial is actually recurrence-free survival in the PAT-CR patients. So we haven't heard that yet, but it's a really important readout, again, to reassure us that de-escalation is not going to compromise long-term outcomes.
So let's get a little bit of a practical input on this. Erika, Susmitha had a bunch of patients she wants to bring up. A couple of them refused therapy, as happens occasionally, or maybe not occasionally. What's your current approach to neoadjuvant therapy, Erika? And in what sense are you de-escalating therapy? What about patients who are very concerned about tolerability?
Yeah, I mean, I typically like to give a neoadjuvant as often as I can. I do tend to try to de-escalate. I think we're getting much more comfortable. We can always give something on the back end, but really allowing kind of biology to tell us who's going to have a good response with that PCR and potentially save patients from having to get more chemo, I think particularly is attractive, especially when agents cause neuropathy, especially when our patients are older and are going to have more toxicity from that. And I think, the Compass HER2 with THP is really compelling data. So if somebody has a smaller tumor, they're no negative, I think it's attractive.
Susmitha, any questions about this? What kind of tolerability issues do you see right now in the neoadjuvant setting?
I think it's definitely the chemo portion, the Taxotere and the carboplatin. I do dose reduce them upfront if I know that my patients cannot handle it. But this sounds amazing. If we can definitely go to 4 cycles and do THP, once we get the data, that would be great for our patients.
All right, well, let's get into that in terms of neoadjuvant TDXD, Shanu.
Yeah, so this was probably the biggest practice-changing neoadjuvant de-escalation trial last year, and that's Destiny 11. This was a randomized phase 3 study, and it was for high-risk HER2-positive patients, which means patients had to have either positive lymph nodes, they had to have inflammatory breast cancer, or they had to have tumors larger than 5 centimeters. And there were 3 arms to the trial. The standard arm was dose-dense, ACTHP. Then there was a second arm of monotherapy, TDXD, for 8 cycles. And then the sequence arm of TDXD 4 cycles, THP 4 cycles. The primary endpoint here was PathCR. And I think, as most of you know, the Data Safety Monitoring Committee for this trial stopped the monotherapy arm early due to low PathCR rates. So this is really a 2-arm comparison study. And just to look at the key demographics, over 900 patients were enrolled. 90% of these patients had IHC 3+ cancers. 75% or 3/4 were hormone receptor positive, and typically we know that's a group that we have a harder time achieving PathCR in. And then finally, importantly, 90% of these patients were node positive. And I should also mention about half the patients on this trial had stage 3 disease. So this really was a higher risk population of patients than other sort of studies in the similar setting. And here are the PathCR results. On the left, you can see dose-dense ACTHP had a PathCR rate of 56%. With TDXD THP, that increased to 67%. That's an improvement of 11%. And when you break it down by hormone receptor status, there was a 9% gain or improvement in the hormone-positive population and a 16% improvement in the hormone receptor-negative group for a PathCR rate of 83%. Pretty impressive. And so I think just given that this was a really high-risk population, I think these results are very clinically significant. These are event-free survival curves. They're premature. There's just too few events so far, but you can already see the trend in favor of TDXD. And just in terms of safety, TDXD also was ahead here. Overall, there was less grade 3 events on the TDXD arm. There was half the rate of serious adverse events. There was substantially lower rate of LV dysfunction. And in terms of ILD, the rates were low and similar in both arms of the trial, a lot lower, in fact, than we see in our metastatic trial. So overall, this was a win-win for patients. We had higher PathCR rate, better safety profile. So for me, I think TDXD followed by THP is poised to become, I think, our preferred regimen for our high-risk neoadjuvant patients. And we should be hearing from the FDA next month.
So again, before you continue, Erika, how does this translate into your practice? Are you only going to use this strategy in high-risk patients?
Yeah, I mean, I think it is most appropriate for our higher risk patients. We also have DB05. We're going to be talking about that. I really think that this data is most compelling for our patients with really large tumors and node positive. But, in contrast to the adjuvant data that I think we're going to go through, I found what was really compelling here was, only being able to use 4 cycles and seeing much lower rates of ILD. In the adjuvant setting, we're really going to have to monitor for ILD. That's a little bit more annoying with CT scans, et cetera, and only having to do 4 cycles here and seeing less than 1% grade 3 or greater ILD, I think is quite compelling to see that higher PCR.
So that leads us right into Destiny Breast 05.
Yeah, so moving to the residual disease where escalation matters a lot. I mean, our reference trial has been the Catherine trial in this setting. I think the bar has now been raised with Destiny 05. So this was another randomized phase 3 study for patients who had high-risk residual disease. That means patients presented with inoperable cancers and had residual disease, or if they were operable, they had to have residual axillary lymph node involvement. And so they were then randomized to either standard TDM1 for 14 cycles or TDXD, and the primary endpoint was the invasive disease-free survival. Again, just looking at the demographics, over 1,600 patients were enrolled. You can see here 80% of these patients had IHC3 plus cancers, 70% hormone positive, and I think that's going to be the bulk of our residual disease population. They're also going to have hormone positive disease. Half of these patients were inoperable at baseline, and that's twice the rate of the Catherine trial. Also, 80% of these patients had positive lymph nodes at residual disease. Again, that was almost double the Catherine population. So this really was a much higher risk population of patients, which makes the efficacy results, I think, even more impressive. So these are the IDFS curves, and you can see here really nicely a clear advantage for TDXD. The hazard ratio is 0.47. The 3-year invasive disease-free survival with TDM1 was 84%, and it was 92% with TDXD, so an improvement of almost 9%. And that benefit was seen across subgroups, so a really, really, I think, remarkable data point. When you look at the first invasive disease-free survival events, it's really interesting to see how effective TDXD was at preventing distant metastases. It was also far more effective than TDM1 at preventing CNS events. And certainly this is an exploratory observation, but I would say it's a very provocative signal. Currently, the overall survival data are, of course, immature. In terms of ILD, there was a higher rate of ILD on the TDXD arm. It was 10%, sort of approaching what we see in the metastatic setting. I would also point out that this is about double the rate we saw in the neoadjuvant Destiny 11 trial, and that's really been attributed, as Erika said, to the number of cycles I think patients get and also to their level of prior therapy, potentially. There were 2 fatalities on TDXD. There were none related to ILD on TDM1. But in fairness, most of the events were grades 1 and 2 ILD events. Overall, the rates of LV dysfunction were low in both arms of the trial. And so what I would say, bottom line here, is this is a manageable profile. And when you stack that up against the dramatic improvement in survival, I still have to say Destiny 5 is a practice-changing trial. And already, in fact, the NCCN has endorsed TDXD for the high-risk adjuvant patient population while we still await the FDA review.
So again, Sue Smith, I'm always curious how general medical oncologists deal with the data that comes out. I imagine there was some time in October where you woke up one day and found, hey, there are these 2 studies that came out with TDXD, neoadjuvant and post-neoadjuvant. What are some of the questions that you had at that point, and what are some of the questions you have right now for the faculty?
So I have not used it in the neoadjuvant space. Most of the experience is in the adjuvant space. So my question is, the residual disease becomes a little tricky. Sometimes patients do present with large tumors, but they end up with a positive lymph node, but it's like a 2 millimeter or 3 millimeter residual disease. So that would be the one scenario I would like to know how they would approach adjuvant therapy.
Erika?
You mean adjuvant therapy if they receive neoadjuvant
TCHP.
Oh, for TCHP.
Because most of my patients have already received neoadjuvant TCHP. I haven't used TDXD.
Yeah, I mean, I think that's the trick here is that conceivably there are some people that would fall through the cracks that wouldn't be eligible for either because recall in DB05 you had to have residual nodal disease. It wasn't, Catherine, just any residual disease. So you couldn't just have residual disease in the breast. So, if you're not using DB11, there is a potential that some people aren't going to be eligible for DB05. But I think if we're using TCHP neoadjuvantly and somebody has residual nodal disease, I certainly think DB05 is extremely appropriate for patients. I think the really tricky clinical situation now is somebody that received DB11 has already had TDXD, has residual disease, and what are you going to give them for the residual disease now? And I think we would probably still give them TDM1. I'm curious of what you would do, Shanu.
Yeah, I mean, my short answer is we have options, right? I mean, we have TKIs, TDM1, we have more chemotherapy and endocrine therapy. A lot of these patients are going to have hormone receptor positive residual disease. The long answer is, I mean, I think it's nuanced. If you've given them TDXT up front, I think the way I would approach it is how well did they perform with TDXT up front? And if there was really no benefit, I don't think giving more TDXT is probably going to help. We typically see fast responses with TDXT and with cytotoxic therapies. So I hear this a lot, like I don't want to use TDXT up front because I'm worried about what I'm going to do in the residual disease setting. And I don't think we should be afraid of that. I think we need to tackle that head on. I mean, that population exists, whether we acknowledge it or not. And it's a wonderful opportunity for us to study and figure out what these patients actually need. So it's a nuanced answer. I think it depends on how well they did with TDXT up front.
So, Shanu, this morning we had your colleague, Dr. Jen Jeejing, here talking about zanidatamab and all the problems with diarrhea that she's been seeing. And we said, well, you ought to talk to the breast people about, how we got around neratinib diarrhea. So maybe you can update us a little bit on in terms of the ExteNet study in neratinib.
So, neratinib is now an old drug, but it really is worth revisiting. The ExteNet was a trial from 15 years ago. Just to remind you all, this was almost 3,000 patients who had stage 1 to stage 3 HER2-positive breast cancer who completed their chemotherapy and trastuzumab, and then were randomized to either a year of neratinib or placebo. And the primary endpoint was 2-year invasive disease-free survival. That was 94% on the neratinib arm, 92% on the control arm, so an improvement of 2.3%, which was statistically significant. And importantly, this benefit really held up even at the 5-year follow-up point of this trial. Unfortunately, it never did show a survival advantage, but the real problem with neratinib was the grade 3 diarrhea. It was like 40% in this trial. So although the FDA approved adjuvant neratinib, it really was not widely embraced. And I want to point out some of the other interesting things from the ExteNet trial. I think it was important to note that the benefits of neratinib were really confined to the hormone-positive population, particularly those who started neratinib soon, like within a year of finishing their trastuzumab. And for those patients, they had an absolute 5% improvement in disease-free survival. They even had a 2% improvement in overall survival. The other group that really did well were the patients who were treated with neoadjuvant therapy and had residual disease. Now, that's a high-risk population, right? But they had a 7% improvement with adjuvant neratinib and a 9% improvement in overall survival. I mean, those are pretty striking numbers, even for an exploratory analysis. Perhaps the most provocative data from that study was the fact that there was a lower rate of CNS events on the neratinib arm, including the patients who achieved PathCR. So, in fact, the European regulatory agencies also approved adjuvant neratinib, but they really limited it to the hormone-positive population. And just coming back to your point, I mean, the real reason neratinib failed to be widely used was the grade 3 diarrhea. So the control trial investigators looked at various different strategies to prevent diarrhea. They looked at aggressive loperamide, adding in budesonide, adding in cholesterol. But the thing that was most successful was a gradual dose escalation of neratinib. So starting at 50% of the dose and then adding one pill in every week. And they were able to bring the 40% grade 3 diarrhea rates down to 15% with only a 3% discontinuation. So now speeding up to the present day, the Eleanor trial is a real-world study of extended neratinib in hormone-positive patients with early-stage breast cancer where they did employ some of these anti-diarrheal strategies. So it was about 300 patients. This was done just in Europe. Most of these patients were stage 1 and stage 2 patients. 80% got neoadjuvant therapy. Half of them had residual disease. And you can see here about a third of these patients got dual blockade. They got H&P. And a quarter of them got TDM1. So unlike Extenet, this study does include a cohort of patients who got multiple HER2-targeted therapies before neratinib. 45% of these patients were treated with that dose escalation strategy, and over 80% got some kind of antidiarrheal prophylaxis. And when you look at the endpoint, I mean, the primary endpoint was adherence, and I mean, they really, over 95% of patients were able to stick to this regimen. The grade 3 diarrhea rate was halved from neratinib. Remember, it was Extenet was 40%, it's 20%. It was actually lower in the patients who did that gradual dose escalation. And then the 2-year disease-free survival rate is 97%. I mean, that's pretty close to being what we saw in the Extenet trial. So overall, this was a really successful real-world trial of neratinib in a modern population, and it really shows its feasibility and its efficacy. What we still don't have is data post-TDXD, of course. And so I was just going to end there by giving you my approach to the higher risk early stage HER2-positive patients. For those who do present, I think as per the Destiny 11 population, the higher risk patients, I would certainly reach for TDXD followed by THP. For those who are TDXD naive and show up with residual disease, like your question or your patient, I would certainly want to use TDXD, although I think we may be limited to a high-risk residual disease population per the Destiny Breast 05. And then finally, I think for the hormone-positive patient who is a high risk of recurrence, I think it's certainly worth considering offering extended neratinib therapy.
So maybe a second opinion on that last algorithm. I'm curious, Erika, are you utilizing neratinib and what situations in the post-adjuvant setting?
Yeah, I mean, I agree. I mean, I think the data is compelling for that super high-risk patient that's also hormone receptor positive. You know, we don't have the data in a modern time with the drugs that people are getting now. I mean, we would estimate that the benefit probably would be a little bit less just because our cure rates are a little bit higher with modern drugs. But again, you know, the brain met data is compelling. I certainly talk to patients about it. I have to say that, you know, quite a few patients are not interested just from a tolerability standpoint. It still is a tough drug, although I think we are better at controlling the diarrhea now with those strategies that Shanu was talking about.
I mean, how much better? What do you say to a patient who says, tell me, you know, what should I expect?
Yeah, I mean, I think my tagline is that we can definitely manage it, but you're going to have to be a person that's willing to take pills to manage it. If you're a person that doesn't like taking medications at home, it's not going to fly.
Any theories about why you see so much more benefit in ER positive?
Yeah, I think it really has to do with crosstalk of the receptors.
I've heard that before, but I don't know what it means. Anyhow, one case from the audience, Shanu, 52-year-old woman, HER2 positive, 1.3 centimeter tumor on MRI, went directly to surgery, but unfortunately had a positive node. What's next?
Right. I mean, for these patients, currently we're going to be using dual blockade and polychemotherapy, right? I mean, this is a high-risk patient. They don't fit into, unfortunately, the current paradigm of the TDXD trials. But this is a patient where I would escalate therapy. I would use usually Taxotere, carboplatin, and dual blockade, which is where we saw the advantage in the affinity trial. If they're hormone positive, this is a patient you could talk to about extended neratinib therapy as well.
So, Susamita, any questions you have localized HER2-positive disease? You got a bunch of cases. Any questions you want to throw out there?
I think the real challenge is the extended adjuvant therapy with neratinib. I do get to a maximum of 4 tablets with all the supportive care. I know that there's new data out there that it's not really dose dependent. The response is not dose dependent. So I wanted to get your thoughts on that.
Shanu?
Yeah, I mean, in these trials, I want to say this, in the Eleanor trial, I think with the gradual dose escalation, they were actually able to get a median dose intensity of almost 230 milligrams. So 6 tabs is 240. I think in all of these studies, and even in the Extenet, what was really key was the duration. Like if you could get close to that 12 months, that subgroup analysis is really where we saw the benefit. So I agree. I mean, you're not going to be able to get 6 tablets, and it's really challenging. So I think if the maximum you can get for as long as possible is the key. And I mean, it's also a challenge because a lot of these patients just came off of having terrible diarrhea from their neoadjuvant therapy. So I think that's another reason when we broach the idea of another regimen that's going to give them like another year of diarrhea, it's a challenge. It's certainly a challenge.
Yeah, tomorrow morning we talk about ER-positive disease. We'll talk about dose escalation of abemaciclib, trying to avoid diarrhea as well. So
right.
That strategy has a lot of applications across oncology. All right, so let's get to maybe one of the trials of the year in oncology in general, but let's talk about HER2-positive metastatic disease. Erika?
Absolutely. So let's dive into HER2-positive. So I think really the 3 probably biggest topics in HER2-positive metastatic disease right now is DESTINY-Breast09 moving into the first-line space, and then really maintenance strategies of patina as well as HER2-CLIMB-05. And then we're going to touch on a couple of kind of older topics but good topics: neratinib, margetuximab, brain mets, and then a little bit of what's up and coming. So a slide just to talk about, if you feel like it's trial by fire, it's not just you. If you look at the right side of this, whether we're talking about TKIs, antibodies, or antibody drug conjugates, there really has been an explosion of drug approvals in the past 10 years compared to historical. So things are moving very quickly in HER2-positive breast cancer. This is kind of what we have historically thought about our treatment algorithm. First line was our taxane, trastuzumab, pertuzumab. Second line was trastuzumab deruxtecan based on DB03. Third line was HER2-CLIMB based on capecitabine, trastuzumab, tucatinib. And then, as I like to call, fourth line was the wild, wild west, where we had a lot of different options. And our overall survival is graphed out over on the right. And you can see a hint of what we're going to see in DB09, but trastuzumab deruxtecan's OS in the second line setting almost looking like what the first line OS was with TEHP in the first line setting. So this brings us to the DESTINY-Breast09 trial, which was designed as a 3-arm trial looking at TDXD plus pertuzumab in first-line disease versus THP, our standard Cleopatra regimen, but there was also a third arm, TDXD alone plus placebo. We have not seen the data from this arm yet. What we've seen the data from is TDXD plus pertuzumab versus the THP. And when we look at this, let me go back to this here. In terms of de novo disease, we can see that over half of our patients now in the metastatic setting have de novo disease. We see this across trials, and the majority of our patients have ER or HR positive disease. Again, we see this across trials as well. And in terms of DB09, our progression-free survival, pretty compelling results. Since I'm from Nashville, we're not going to drive a truck through it. We're going to put guitars in between the curves here. Our hazard ratio of 0.56, and this is essentially a PFS of almost 14 months different, favoring TDXD in combination with pertuzumab. PFS now is in excess of 40 months in the first-line setting. When we look at the split by HR-positive or HR-negative disease, you can see that this is highly statistically significant regardless of whether a patient has endocrine expression in their tumor or not. And then in terms of safety, I don't think that there's any big surprises. We know that we have to monitor ILD, and we know that nausea is a prominent side effect with TDXD. We've gotten much better at managing nausea. We know that this is highly emetogenic. We're giving a 3-drug antiemetic prophylactic regimen, not in response to nausea, but really prophylactic. And we also know that compared to naked taxane with trastuzumab and pertuzumab, that we get less neuropathy and less neutropenia with TDXD and pertuzumab. So in terms of evolution of what we've seen with TDXD from Destiny Breast 02 in the third line setting, you can see our benefits of TDXD over treatment of physician's choice down on the bottom. We moved it into second line with DB03, and we saw TDXD at 28.8 months. And now that we're moving TDXD in combination with pertuzumab in the first line, we now have a PFS of over 40 months. So a lot of people asking the question of, well, TDXD is really beneficial regardless of when you give it. So why am I giving it first line? And the statistic really is that a third of our patients are not going to receive subsequent treatment after the first line. And I think that's challenging for all of us to believe. I certainly find that challenging to believe in my clinic. But whether that's brain mets, whether that's performance status decline, that really is the statistic that a lot of our patients don't go on to continue to receive subsequent lines of therapy. So we really shouldn't be saving good drugs for later. So this brings us to our newer maintenance strategy. I'm going to be remiss if I don't mention Patina. Patina was also a maintenance strategy trial. This looked at palbociclib for our patients that have HR-positive disease. Very compelling data. HER2-CLIMB-05 was a little bit of a different maintenance strategy in the fact that it allowed patients, whether they had hormone receptor positive or negative disease, but a very similar trial design. Patients were induced with THP, Cleopatra type chemotherapy. They were progression free after 4 to 8 cycles. They were going to go on to HP maintenance with or without endocrine therapy. They were eligible for endocrine therapy if they had HR positive disease, and then they received placebo or tucatinib. Again, the majority of patients had HR-positive disease. Brain mets were pretty infrequent. Again, we're talking about a first-line patient population, about 12% of patients, and almost 70% of our patients actually had de novo metastatic disease here. So this is definitely something that's evolving over time with more and more of our patients in the metastatic setting being de novo because we're curing most of the patients that we get our hands on in the early setting. This is what we saw. We saw a benefit of adding tucatinib of almost 9 months. PFS lengthened from 16.3 up to 24.9 months. And when we look at this broken out by hormone receptor negative or hormone receptor positive, we did see a greater benefit for those patients that were hormone receptor negative, a little excess of 12 months benefit in PFS, but we did see a benefit for those patients that were hormone receptor positive of about 7 months, and both of these subgroups were statistically significant. In terms of safety, I think we all thought that maybe diarrhea was going to be a pretty big side effect here. We know we can see diarrhea with pertuzumab, certainly. We know we can see diarrhea with tucatinib. But I think actually very reassuringly, diarrhea was actually a very infrequent reason for discontinuation of tucatinib. You can see highlighted in red here that only 1.5% of patients discontinued tucatinib due to diarrhea. And in fact, the most common reason for discontinuing tucatinib tucatinib was actually due to AST/ALT elevation. We certainly saw diarrhea in both arms, but it really appeared that most of this diarrhea was driven by the pertuzumab and not the tucatinib. This really wasn't, I think, super surprising, because I also think that most of the diarrhea in the HER2 Climb regimen is actually driven off of the capecitabine and not the tucatinib as well. We also saw nausea, but definitely need to check the LFTs and monitor these as well.
So in a second, I would like Shanu to tell me a little bit about how she's thinking through upfront therapy in the HER2-positive. Simple question, how are you? When are you using TDXD? How long do you use it? What are you doing about maintenance? But before you do, I was just kind of flashing. I've heard about these poly-market things where you bet on whether things are going to happen. Like people bet on whether Venezuela is going to be invaded and all this. I was wondering if they have a poly-market thing to predict what's going to happen in clinical trials, which leads me to ask you, what do you think the TDXD alone is going to show? Same or different with pertuzumab? Are we going to be using pertuzumab in the future? Erika?
I find it a little bit suspicious that we haven't seen the data yet. I would have anticipated us already having seen that data. I am not sure that we're going to see a gigantic benefit of adding pertuzumab compared to what we see with TDXD alone.
I think we will.
I hope we do, because it's going to make it a lot
easier for the patient
to go to maintenance.
All right, well, let's get into more practical issues, like what are we going to do? What are we doing right now? So, Shanu, any thoughts?
Yeah, I mean, we only had one first-line option for more than a decade, so this is really amazing. Suddenly we have 3 if you bring in patina. The reality is THP really served us well, right? And it's kind of an unfair fight between THP and then TDXD plus P forever. I have to tell you, I want to take the advantage for the patients of the TDXD plus pertuzumab. It had a higher complete response rate. I mean, it blew THP out of the water in a head-to-head, but I don't think people are going to be able to stay on TDXD plus P forever. So I think most of us are going to sort of use it until the patient has reached maximum benefit or really is starting to run into toxicity issues. So my preference is going to be to use TDXD plus pertuzumab, but sort of in a modified format, sort of following the Cleopatra model. I think there are probably patients who would do just as well with THP and a patina maintenance as well. I'm going to cherry pick those patients, for some reason they don't want to lose their hair. That's a deal breaker. They have a risk for ILD, for example. So I still think THP is going to be an option in the background.
Erika, what are your thoughts, and what are you thinking about in terms of maintenance? I've seen algorithms where they say ER negative, go towards HER2, ER positive, go towards patina. What about palbo and tucatinib?
Yeah, we don't have any data with palbo and tucatinib. I don't think we can double dip here. I think that split by ER is pretty fair. I think that there's some circumstance that I may not follow that. I completely agree with Shanu. I don't think I'm going to do TDXD plus P indefinitely. The clinical trial purist would, but I don't think that that's quite reasonable. I'm similarly also not going to stop after 6 cycles. I'm going to treat patients to maximal response. The CR rate was double. I'm going to get patients to that deepest PR or CR that they can get, whether that's 12 months, 14 months, 16 months. Then I'm going to be thinking about maintenance.
All right, let's move on. We're back to neratinib.
Okay, so we're going to go quickly through this part of the section. Again, just a reminder of capecitabine, neratinib. This trial, NALA, looked at cape neratinib versus cape lapatinib. Again, just showing that neratinib was really a superior TKI. I'm not going to go through the tolerability. Again, I think we've gotten better at managing this, but this really was a more heavily pretreated population of patients that had multiple lines in the metastatic setting. We also have Sophia, which was margetuximab. This is really kind of a new and improved trastuzumab with optimized FC binding. 4.9 months with chemo trastuzumab versus 5.8 with chemo margetuximab. This was statistically significant. I think we all can see that the magnitude of benefit was not blow it out of the water, but certainly a different antibody for our patients that are much more heavily pretreated when we get to later line therapies. I think we're remiss if we don't talk about brain mets in metastatic HER2-positive disease. HER2-positive disease is really the subset where we see brain mets most frequently. Up to 50% of our patients with metastatic disease ultimately will face brain mets at some point during their treatment journey. And really, the first great quality data I think we got with brain mets was part of the original HER2-Climb study. Of that, about 48% of the patients on trial had brain mets. You can see the breakdown here. Some of those were treated in stable brain mets, but we also had a subset within the trial that had active brain mets. Some of those patients had untreated brain mets, but some had treated in progressive brain mets. And when we looked at those patients that had brain mets, the CNS progression-free survival data highly favored tucatinib, a hazard ratio of 0.36, and the PFS over doubled, 4.1 months up to 9.5 months. And when we looked at CNS overall survival, a very similar story, hazard ratio of 0.49 and 11.6 months of survival, 20.7 months. So really the risk of developing new brain lesions or death was reduced by essentially half. We now have better data in terms of trastuzumab deruxtecan. I think we were all kind of with DB03 saying this is not comparing apples to apples. DB03 didn't enroll patients that had active brain mets, but now with Deborah and a few other studies, we do have data with patients that had active brain mets, patients with progressing brain mets, even here in cohort 5, patients with leptomeningeal disease that were treated with trastuzumab deruxtecan. And you can see that we're seeing some good responses here. PFS survival at 6 months, 80%, 9 months, over 50, 60%. So really encouraging not only extracranial activity with trastuzumab deruxtecan, but also intracranial activity. And I think really exciting to see some of this data, even with leptomeningeal disease, which has really been kind of, on an island with very few options. We also have Tuxedo, which looked at trastuzumab deruxtecan. These are all small numbers. We're talking about active brain mets here, but looking at objective response in the CNS by RANO-BM criteria. But look at these responses. I think, crazy impressive, 73% response rate, clinical benefit rate approaching 90% in the intention to treat, and patients with measurable extracranial disease responses in essentially 62%. So I think we can clearly say that even though trastuzumab deruxtecan is a large antibody drug conjugate, it definitely gets into the brain, and it is definitely an active compound for our patients with brain mets.
Quick question to Sandra from the audience. 54-year-old woman, ER-positive, HER2-positive disease, has a path CR to CCHP and gets a post-op therapy, has a solitary brain met. It doesn't say how long afterwards that's resected. No systemic disease. What would you do at this point?
I mean, I have patients like that in my practice. It's really incredible. The PAD-CR patients are still susceptible to brain mets, and I think we have to look back at the burden of disease patients have. There's still high risk sometimes based on that. In our own review at MSK, half the recurrences in PAD-CR patients were brain mets, actually. So this patient doesn't have systemic disease, so you kind of feel bad giving them a drug like TDXD. You kind of want to leave it for a rainy day, which they may or may not have. So I do feel motivated. We know these patients sometimes will continue to have CNS relapses, so this is where I would use a TKI. And I think in general it's better tolerated. I can't tell you there's data for it yet, but there is sort of an evolving paradigm of using the HER2-Climb regimen. The CAPE and the tucatinib both have CNS penetration with trastuzumab, and then at some point you back off of the capecitabine and try and maintain these patients on dual blockade, but this time with the TKI with trastuzumab.
Mute SRS, that lesion.
Of course, after the isolated therapy, I think you said it was resected. So yes, SRS as well.
New agents, Erika.
Okay, so I'm going to go through this quickly just to say that we're not done. This slide's going to get more complicated. There's a lot of agents coming. We've got new bispecific antibodies. We've got new tyrosine kinase inhibitors. We've got new HER2 vaccines. I'm going to touch on zanidatamab. I know you guys talked about this during the GI session. So essentially, zanidatamab is a biparatropic antibody. It hits both extracellular domain 2 and 4. So pertuzumab binding site as well as trastuzumab binding site. But it's not just pertuzumab and trastuzumab together. It actually leads to cross-linking on the cell surface and really an activity above either of these just in addition. It's approved in biliary tract cancers. And so we can have great activity in a phase 1 trial where we combined with a variety of different chemotherapies. The response rate in heavily pretreated HER2-positive metastatic disease was over 40%. Diarrhea can be a prominent side effect here. We also saw some neutropenia, mainly from the chemotherapy backbones. But you can see the waterfall plot, and there's an ongoing phase 3 enrolling, which really looks at chemotherapy trastuzumab versus chemotherapy zanidatamab, which is essentially 3rd to 5th line metastatic disease right now.
Just kind of curious because Dr. Janjigian, I was surprised when Dr. Janjigian was really concerned about the diarrhea because we heard from the biliary people, no, it's not a problem. What's your experience?
I mean, it's similar to TKI diarrhea. So,
like neratinib?
I wouldn't say it's as bad as neratinib. No, I'd say it's more of a lapatinib diarrhea, maybe.
Interesting. All right, so here's a really interesting one. Somatic mutations. I want to hear what you have to say about that because in lung cancer it's getting pretty interesting.
Yeah, we definitely see HER2 mutations. Interestingly, HER2 mutations don't happen in HER2 positive breast cancer. It really happens more in ER positive breast cancers. We can see mutations in the kinase domain. We can see mutations in the extracellular domain, but most of them actually occur in the kinase domain. And there are a lot, 36 unique HER2 activating mutations, but not all mutations you'll see on an NGS report are activating. So definitely worth kind of looking this up to see what you're actually looking at. We see this in about 2% of primary breast cancers, about 2 to 4% of metastatic breast cancers, about 8% of ER-positive metastatic breast cancers, but up to 15% of metastatic lobulars. So that's really where it's enriched, are these hormone receptor positive luminal A kind of lobular breast cancers. We've got data mainly from the TKIs. We've got Mute-HER here. This was neratinib. You can see 21 of 22 cases here did have hormone receptor expression. Clinical benefit rate was about 31%. And then this was the Summit trial. Over on the right, you can see fulvestrant trastuzumab, but over on the left of this is where we added in neratinib, and you really see some of the great responses for these patients. So with the fulvestrant trastuzumab neratinib combination, response rates 42% and progression-free survival 7 months. Encouraging data here with Summit. We also have tucatinib and trastuzumab in a basket for HER2 mutant breast cancer. Some really great responses here. Response rate about 41%, median duration of response about 1.5 years here. So I'm going to leave with an algorithm, the same as Shanu did, but this time for metastatic disease. I really see trastuzumab deruxtecan in combination with pertuzumab as the new standard. I also agree that for some patients, taxane, trastuzumab, pertuzumab might be appropriate, but I really think that most patients are going to deserve this, improved induction regimen with TDXDP. It has double the CR rate, et cetera. I don't think that most patients are going to continue it indefinitely. definitely. I do think that we're going to be looking for maintenance regimens, whether that's a patina or a HER2-CLIMB-05. I think that now that moves a HER2-CLIMB, a capecitabine, trastuzumab, tucatinib up into the second line, unless somebody was on tucatinib maintenance. We certainly can go back to TDM1 now, and then we have a host of clinical trials as well.
So the question, please.
Just a summary on HER2 mutant breast cancer. I think it's important to remember that this is really distinct from HER2 amplification, and that we really want to remember that this tends to be in ER-positive breast cancers, and particularly lobular breast cancers.
So what I want to hear about from you, Erika, is, again, in lung cancer, they've realized that most of these mutant patients, which they were treating with T-DXd, have this TKD mutation. They've got 2 new TKIs, zongertinib, which you had in there, now approved first line, and cevabertinib, another TKI. You look at the waterfall plots, everything goes down. It looks like EGFR. It looks like osimertinib. But there's a pan-tumor trial now, because you see this, as you just mentioned, in other cancers. So my question is, you have a patient with this TKD mutation, are you going to give them zongertinib?
I absolutely would. It's funny. I think HER2 and ADCs, we're maybe a little bit more advanced in breast than some other tumor types, but I think with HER2 mutations, honestly, I think our lung colleagues are a little bit more advanced than we are in some of their trials.
Yeah, it's really an amazing story. These are non-smokers. I mean, it looks like EGFR again.
Absolutely.
Anyhow, why don't we finish out Susmitha? Any final questions or cases you want to run by him?
So I do have a high-risk stage 3 ER-PR-positive, HER2-positive patient who I'm going to offer extended adjuvant therapy with neratinib. Any experience with CDK4/6 inhibitors in that space, in the adjuvant setting, high risk? And my second question is, we do have a few patients who are metastatic but are on single-agent trastuzumab or combination of trastuzumab with pertuzumab. What do you discuss with these patients? When do you stop their treatment if they have no evidence of disease?
Shanu?
So I'll take the first question first about. Oh gosh, I forgot your first question.
Stage 3 adjuvant.
And adjuvant CDK4. So actually, there was a trial. Lilly had a trial briefly in HER2-positive, hormone-positive patients with using abemaciclib in the adjuvant setting, and they abandoned it because it was just becoming clear that the HER2-positive patients were suffering from our treatments like just forever. And they could see the landscape was changing and T-DXd was coming, and so they actually stopped that trial. I think it's time to revisit CDK4/6 inhibitors for the triple-positive population. And as we were saying earlier, the residual disease population is going to become more and more hormone-positive, HER2-positive. And I think that's a question that begs to be answered in a trial. Do we need to give these patients who maybe will get T-DXd up front, who have residual disease and they're triple positive, do they need more TKI? Do they need more chemo? Or should we now focus on really optimizing their combination endocrine therapy? I will tell you, on a select basis, I have been able to get an adjuvant CDK4/6 inhibitor approved for a patient with very high risk triple positive breast cancer, lots of residual disease, didn't seem to be responding to their traditional neoadjuvant therapy. So prioritizing between the two, whether you want to use neratinib or I think, or the CDK4/6, I think that's going to be a toss-up, and depending on maybe the biology of that residual disease, sometimes they're HER2 negative after they've had all that therapy, in which case leaning in towards a CDK4/6 inhibitor might make more sense.
I don't know if my memories are accurate or not, but I think we talked about the fact that there's going to be a plenary presentation at ASCO on abemaciclib in sarcoma, soft tissue sarcoma. And at SGO, we had a case presented by Ursula Matalonis, a patient with endometrial cancer, had a complete response to abemaciclib plus hormonal therapy.
Yeah,
so
they're great.
We're getting into a pan-tumor territory. Anyhow, tomorrow morning we'll be back talking about ER-positive breast cancer. Thanks so much to the faculty.